Okay, so as you can see, what we're going to be talking about today are the common ingredients of psychological healing. And I'm going to be looking at this from a Jaynesian perspective. So, some of these ideas that I'll talk about today, I have already touched upon in previous discussions. Some of you who were involved in those discussions, hopefully, this will be just sort of a recap of some of those ideas. So if you're new to this, some of the ideas may not make a lot of sense right away, but of course, as always, that's no problem. We'll go through this step by step, and if anything needs to be explained, of course, you can just ask. So let's begin with the question: why do psychotherapies work? Unlike in the biomedical field, it's a lot more difficult to pin down how the mind heals itself, because when we when we talk about the mind, we're not talking just about the brain, we're not talking just about our neurological apparatus, we're talking about information and networks of meaning and self-identity. And these things, of course, can be described, but when it comes to measuring in a very rigorous way the mind, mental processes, it becomes quite challenging. So uh, let me begin by saying that the approach I'm going to be taking today, in order to begin to answer this question, why do psychotherapies work, is because of common factors. And we'll talk in a moment about what I mean by common factors. But the idea here is that positive outcomes are not due necessarily to a specific approach or system of therapy. Okay. So when I say system of therapy, I mean all the different schools or traditions of psychotherapy: Freudian, Jungian, cognitive behavior therapy, um, a system developed by Adler, who was a student of Freud, newer systems of therapy, dialectic behavior therapy, acceptance and commitment therapy, Gestalt. So in any case, there's probably there are about, depending who you ask, maybe 12 to 16 major systems of therapy. And the idea here is um, they all have something to offer. They all look at the human condition from a different angle. But what do they have in common? And that's what common factors is all about. And later on in today's discussion, of course, I'm going to change the angle a little bit and look at all this from a Jaynesian perspective. So that's the key question. Why do psychotherapies work in the first place? So many researchers in the field of psychotherapy have come to the conclusion, not everyone agrees with this, I want to emphasize, but a good number do, that in principle, it makes no difference which psychotherapeutic system or school or tradition that you use. And here I list some of the key systems. They all have something to offer, but at the same time, probably they all work because they are relying on the same basic ingredients. So the question is, what are those ingredients? This search for for common factors, the search for common ingredients, has actually been going on for quite a while. It can be probably traced back to the 1930s. And recently, there's been a lot of very exciting and interesting research in the field of common factors. So the first key point I'd like to make, or I should say, what I'm going to try and do today, is to link Jaynesian psychotherapeutics to common factors. And what I have here, this graphic, this is just an example. I just pulled this off of Google somewhere, of one study that made an attempt to look for common factors. And let's see here. So again, there are many, especially recently, many attempts, many research projects to try to ferret out the common factors. And here they look at placebo expectancy. In other words, the idea is that the mind is geared to heal itself anyways. People come to a clinical setting, or they come to a session with certain expectations that they are going to be healed. So that plays a role, 15%. And then relationship, it's a little unclear to me what they mean specifically, but I'm going to guess when they say relationship, 30%, the relationship specifically between the therapist and the client. In fact, in many studies, that seems to be primary. What type of, it's called Therapeutic Alliance or a working relationship. What is the interpersonal dynamic? What's going on between the client and the therapist? If you don't get that right in the beginning, chances are it's going to be very difficult to do successful psychotherapy or to have a positive outcome. Extra therapeutic events, 40%. Again, I'm not clear on exactly what they mean from this study. Extra therapeutic events probably just means what has been going on in a patient's life. But what's important is technique, 15%, only 15%. So technique, probably the techniques that people rely on are informed by a particular system of psychotherapy, whatever that system is. As I said, there's probably about 12 to 16 of them, depending how you count things. But actually techniques, probably, again, depending who you ask, there's probably dozens, maybe 100 or 200 different types of very specific techniques that different systems of psychotherapy use. But as you notice, it doesn't really matter what the particular technique is. Okay. Instead, so the relationship between the client and the therapist is very important. In any case, this is just one example of an attempt at looking for common factors. Not necessarily common factors, but in other words, in general, I should say, in general, what works in therapy. And as I said, technique only 15%, right? So that's not very impressive. Okay, wait a second. This is not. For some reason, my I don't know why it's not moving, but apparently
it is now on second key point.
Okay. All right. So second key point. I want to emphasize something. So a Jaynesian psychotherapeutics is not a new or novel system of therapy or treatment. That's not my interest. Rather, a Jaynesian psychotherapeutic perspective is an attempt to highlight what are the healing processes from all the different systems. What do these different systems share? Okay. So that's important. It seems like a lot of people in the field of psychotherapy, many people have come up with what they think is a new and original type of system or treatment. And many times they're reinventing the wheel, or many times they're relying on what, of course, I call common factors. So in any case, if that's an important point, this idea that a Jaynesian psychotherapeutics is looking at what we already have, what psychological processes already do. All right. It is not a novel system of therapy or treatment. And of course, if that's not clear, if anyone has any questions about that, we can discuss that later. Again, I don't know why my
what is happening?
I don't know. The PowerPoint is not
you can go ahead and let me see, maybe close the PowerPoint and start it again.
Yeah, let me
stop presenting and then start again.
Okay.
Okay, let's try.
Wait a second here. I'm losing all the controls. Is it?
Yes. Now we can see the slide, but it's not maximized yet.
Okay, let's see.
You can go to slideshow. Yeah. Yeah. So we're at the beginning. Perfect.
Okay, so hopefully this will work. So,
Yes.
so as I was saying, just to repeat that second key point, I'm not making any claims. I'm not trying, in a sense, I'm not doing anything terribly revolutionary here. I'm looking for the common factors that different systems of psychotherapy share.
So Brian, can we pause for, can you go back to the slide where it shows the pie chart of the factors? Okay, so this is really stunning, right? Because many of the psychotherapists pride themselves on that it's my method which is working. And what we are saying is that, there is placebo 15%, but it's kind of relationship and extra therapeutic events. That's like 70% of the whole thing.
Right.
So that's a stunning fact.
Yes, it is. It is. And I want to emphasize that, as I said, I just pulled this off of the internet somewhere, this particular graphic. This is just one study. It gets and it's a bit old. It's 1994. It actually gets very complicated. Some more recent studies, they really break things down. They really slice and dice. But in any case, yes, it's important that you point that out, that it is stunning. Because as you seem to say, people assume that, well, a certain system of psychotherapy is going to be superior to another, and another is going to be inferior. And that's really apparently not the case at all. There are a lot of common factors, but besides common factors, there are other things, extra therapeutic events. And that gets even a little more complicated. And that has to do with what the particular client is bringing to the session, or what is going on in the client's life. So it's probably a little more complicated than I'm presenting it here, but in any case. Okay, so so we discussed that second key point. And then so as I said, this has been going on for a long time. Many have attempted to identify common factors to explain the effectiveness of psychological treatment. These factors cut across the various approaches and systems and techniques of psychotherapy. So the idea here is that many people have tried to bottle common factors to come up with active ingredients. And this is just another study that was done a while back. It actually basically, it's very similar to the other one, just the wording is a little bit different. But again, therapeutic techniques coming from specific systems of psychotherapy is only 15%. Therapeutic relationship, about a third, 30%. That's very important. Other characteristics, or other client characteristics, 40%. And then client hope and expectancy or expectations, 15%. So in any case, that's just another example. So this is just a little bit repetitive here, but the common factors approach versus specific therapy approach. Now, there are still some people who are not big on common factors, or believe that not enough research has been done on common factors to make these claims. Some people are trained in the specific systems of psychotherapy that they feel very comfortable with, that they think works, and they may be critical of other schools, and that's fine. But in any case, just to sort of put things in a simple format, the argument here is common factors versus specific therapeutic approaches. So I don't want to read this too much line by line, but as you can see, it says here, common factor approach contrasts with the view that the effectiveness of psychotherapy is best accounted for by differences in specific psychotherapeutic treatments or particular methods or procedures. So that sums everything up, what I've been saying so far. Some of you may be wondering why I have this graphic of the makings, the ingredients of stew. Well, because that's how I think common factors should be looked at. Common factors, it's not just one or two things. It's a constellation of different things. And of course, we have to really pay attention to the individual client. So for example, a client may be allergic to carrots, or there may be a specific technique or treatment and intervention that doesn't really work with a client. So we have to pay attention to that. But probably most of the ingredients are going to work for most clients most of the time. There are exceptions that we have to pay attention to. But in any case, that's how I look at it, is what are the basic ingredients. And there's been a lot of work done actually on how certain ingredients work better, as I said, depending on the client. And also very important, this concerns time, temporality. This is something that I've talked about before, the relationship between the mind and time. So clients may come in and they just may not be ready for certain factors. They may not be ready for certain ingredients. It's very important to try and gauge how prepared a client is. Where are they on their in their own life? How willing are they to accept a particular treatment? So again, I just want to emphasize, this is I'm giving a very thumbnail sketch, a very basic explanation of these things, but there are other variables that are very important in treatment, such as the one I just pointed out, this idea of time. How ready is a person for a particular treatment? So this is just another study that was done more recent, about 7 years ago. Another attempt to isolate common factors. And as you can see here, the common factors add up to about, I think, 46%, somewhat less than 50%. The goal, consensus, collaboration. In other words, are the therapist and the client on the same page when it comes to formulating goals or objectives that want to be achieved using therapy? Then empathy. I think that really relates to the relationship between the client and the therapist, of course. Alliance, therapeutic alliance is probably what they're talking about. Sometimes we call it a working relationship between the client and the therapist. Positive regard or affirmation. So is the therapist validating the patient? Congruence, genuineness, how authentic is the therapist vis-a-vis the client? Is the client picking up on a positive attitude, on an attitude that the therapist generally does want to help them? And the therapist's differences, personality differences, I suppose. And then if you notice specific ingredients, it's actually treatment differences among different systems of psychotherapies. That accounts for, actually, it's supposed to be less than 1%, which is really striking. The other 50 or so percent, I'm not sure, it's not listed here in this this PowerPoint, but I think it's probably it has to do with extra therapeutic factors. Again, perhaps what the individual is bringing to the session. But in any case, the point here is that common factors account for close to 50% of positive outcomes. And then the second point is that the different systems of psychotherapies, the differences between them do not count for much at all. And again, this is one study. I mean, not all therapists, not all researchers will agree with this, right? These are, some of these studies are very sophisticated, and the more sophisticated a study becomes, of course, that often leads to problems, but in the results. But in any case, again, this is just one illustration of the search for common factors. And if you notice that picture there, that's from Alice in Wonderland, of course, and that's the dodo bird. And in Alice, I forget exactly what happened in Alice in Wonderland, but apparently there was a race, and the dodo bird, I don't know why, decided that everyone should win the race. There should be no losers. And so many psychotherapists talk about what they call the dodo bird effect, that all systems of psychotherapy have something to contribute. All systems of psychotherapy get us to where we want to be in terms of positive outcomes, positive treatment outcomes. And so again, this goes back to the idea, well, what's going on there? Why are they all working? What common factors do they share? So what I'm trying to do in my project is link common factors with a Jaynesian perspective. And to sort of narrow that down a little bit, what I'm looking at are the features of conscious interiority. And I've talked about this before in different discussions. So features of conscious interiority, that's just a more awkward way, I suppose, to refer to consciousness or conscious interiority or Jaynesian consciousness. And of course, as I've discussed many times before, the problem is with the word consciousness, because when the word consciousness pops up, people have all types of different interpretations and meanings and definitions of what they believe consciousness is. But I'm using consciousness in a very specific way here, of course, from a Jaynesian perspective. And one of the ways I try to emphasize that is by using this acronym FOCI, for features of conscious interiority. So the point that I'm trying to get across is that what I believe is going on is that one very important common factor, excuse me, there's a group of active ingredients that assist in psychological healing, is Jaynesian consciousness itself. Okay, that's basically the point of my talk today, that a key common factor is consciousness itself. And the problem, I think, is this is often ignored or difficult for people to understand. It's hard for people to get their minds wrapped around this argument. I think the reason why is because we take consciousness for granted. Many of us don't interrogate our own subjective, introspectable self-awareness. Consciousness is like the nose on our face. I mean, it's something that is that we grow up with, that we use to think with. We don't even really know what it is. It's sort of like what water is to a fish, or what air is to a human being. It's everywhere. We don't interrogate it. And what I'm trying to do is show how we need to come to terms with the nature of consciousness, as challenging and as difficult as that is, because consciousness is a very important ingredient that allows the mind to heal itself. In fact, consciousness, it's not just about healing. Consciousness for modern humans is how we accomplish so many things. And again, some of what I'm saying may not make a lot of sense unless you're familiar with what James had to say about the cultural development of consciousness. But in any case, if that's not clear, we can address that later. But I just want to emphasize the point here that I suspect many people might have a difficult time with this, because it's, I don't want to say it's a subtle point, but it's certainly something that we are not used to thinking about, how subjectivity itself, how subjective introspectable self-awareness itself can be harnessed. the features of conscious interiority can be cultivated in order to help people heal their own psyches. So to be a little more specific, these are things I've talked a lot about before. This is a list of what I think are probably the key features of conscious interiority. James, in James' writing, in his book, actually, he identified about 5 or 6 of these. I've expanded his list a bit, made it a little more elaborate and complicated. So today, I'm not going to go into a lot of detail about all these different foci. Of course, if people have questions, they can ask about that. And in the future, I plan on talking about these more specifically. And I think it's better to do it that way because we just don't have time. It gets a bit overwhelming to try and explain what each of these foci are about. And, you know, there's nothing terribly complicated about what these different features of conscious interiority are about. Again, we're just not used to slicing and dicing the stream of consciousness in such a way to actually figure out what is going on in our minds. What is Jaynesian consciousness anyway? We're just not, very few of us are used to doing that. And this is the problem, because even people who are highly credentialed with PhDs and MDs, whoever, if you really haven't sat down and tried to understand the fabric of subjectivity, some of this is very new and won't necessarily make much sense. So the analogy I use is trying to understand time and space from Einstein's perspective. I mean, we feel we all have a pretty well-developed intuition of what time is, what space is, but actually, if you look at time and space from an Einsteinian perspective, it's something very different. And if you look at physics from a quantum perspective, time and space become even more strange and more weird. But again, we think, we feel that we're confident, we know what time and space are, but actually, from the point of view of advanced physics, we really don't, right? This is the same thing with consciousness. The same thing, another way, a more awkward way to talk about it is what I call subjective introspectable self-awareness. So in any case, as I said, what I plan on doing in my work is talking about and showing how these different features, these different aspects of conscious interiority all have value. They all have the potential to help a mind heal. We just have to identify exactly how they do that and what these particular features are all about. Okay. So this is a chart. If you look at the top, you have various systems of psychotherapy. I just listed some of the key ones that came to mind. Again, it depends who you ask, what should be included there. And then in the middle, specific techniques and treatments that these systems of psychotherapy rely on. There are a lot more of those techniques and treatments that in the future we can talk about in more detail if you're interested. But underlying them all, the foundation, what they all sort of rest upon are common factors. And as I said, different researchers have come up with different lists for common factors. My particular interest is showing how Jaynesian consciousness or the features of conscious interiority function as common factors when it comes to explaining how the mind is able to heal itself, and not heal itself, not necessarily just when there's been some sort of trauma or some sort of diagnosable mental illness, but at the everyday level. So this actually, I wasn't prepared to talk about it too much today, but I want to emphasize that this search for an understanding of features of conscious interiority as common factors is not just about mental illness. This is also about mental health. These are things that we can all use. We don't necessarily have to have a mental health crisis or a mental health diagnosis or some problem we go to counseling for. These common factors relate to self-improvement. Okay. These are things that whoever we are, from whatever is going on in our life, if we can learn to cultivate these different features of consciousness interiority, I think it makes us into more resilient, stronger individuals. It's the same. It's like muscles of the body, or as we age, especially, we want to make sure that we're taking care of our bodies. When it comes to our diet, we want to make sure that we're taking care of our physicality. Make sure that we're exercising certain muscles. We're getting out, getting sunlight and fresh air. If there's an injury when we're going out for a walk, we want to identify what that muscle is that needs more treatment. Or maybe if we're weak, maybe not an injury necessarily, but if a certain part of our bodies are not in shape, we want to find out, well, what's not in shape, what needs attention. Well, this is the same thing with consciousness or conscious interiority. It has different aspects, and in order to self-improve, in order to engage in some sort of healthy self-change, we also have to pay attention to the different features of subjectivity. So again, I want to stress that this is just not about clinical psychotherapy. This also applies to all of us, no matter what is going on in our lives. There's always something about our minds that we can improve. But our minds are so slippery. It's so difficult to describe psychological processes that it's very easy, unfortunately, to overlook what certain aspects of the mind can be improved. So, to sort of wrap things up or conclude, in order to put a little more flesh on the bones, as it were, because I think that a discussion like this can very quickly become a bit abstract. What I want to do is just focus on one feature of conscious interiority. So, of course, it comes from this list. On the top of the list, the first one, mental space. So I'm going to spend a little bit of time talking about that particular feature of conscious interiority. So mental space can be described as an introspectable stage for manipulating mental imagery. So mental space, actually, according to James, is really the most basic, in a sense, the most primitive or elementary feature of conscious interiority. So the other features of conscious interiority are built upon mental space. So I think mental space is a good place to begin. And mental space, of course, is where we believe or imagine that mental images dwell. Usually those mental images are visual. They are often also auditory. It's very, in fact, that it's rare to have other types of mental images. Usually they only operate in those two modalities, those two sensory modalities of visual and auditory. But in any case, so mental space is very important. And of course, if you're familiar with Jane's argument, he made the startling claim that it was not until about 3,000 years ago that people could imagine a mental space existing within the individual. And that was not, that was a cultural invention. It had nothing to do with biological evolution. And I think that's why many people have a hard time with Jane's trying to understand that point, because they assume that mental imagery or mental space is something that people are born with, where James made the argument that people are not born with it. In fact, it's something that has to be culturally acquired through metaphoric language. So in any case, so these are just some metaphors, metaphoric expressions that I borrowed from some clients of mine, that show how people think or believe, they assume that there is this space in their head. It may be imaginary, but it's still some sort of experience. So I hate being in my own head. My head is like an attic full of junk. My head contains corrupted files. My head is a bad neighborhood that you don't want to be alone. Better stay out of this neighborhood. One patient said, tapping his forehead. Therapy is like someone from the outside looking in, as if his inner essence was somehow inside him. Actually, I can't see the, whoops. In any case, I can't see that whole, yeah. So therapy is like someone from the outside looking in at me. So in any case, again, there doesn't seem to be anything terribly new or revolutionary, perhaps, about these examples. But the point is, people did not necessarily believe that mental space existed inside them. And they didn't necessarily believe it existed in their head thousands of years ago. In fact, the idea of that things live in that images dwell in your head is very much, I think, an Indo-European way of looking at things. In other cultures and other societies, mental space, what we call mental space, often exists in the heart or in the torso, not necessarily in the head. But that's a topic for another day, perhaps. So mind space or spatialization, as I said a minute ago, this is the most primitive feature of conscious interiority. It is the cornerstone of our ability to adopt an imaginary, conjectural, subjunctive mentality. So why is this psychological capability so important? Mental space is a place to more clearly formulate goals and objectives. It affords us a secret simulated stage on which one can rehearse behaviors that require practice or are too risky if carried out in the physical world. So just let me stop here and mention, so some of you may be in counseling or psychotherapy, so you'll of course know that using mental space and the images that dwell in mental space is a very accepted, a very basic, it's a real staple of treatment in counseling. Many people take it for granted, but counselors, of course, will try and zero in on a problem by using the individual client's ability to conjure up images in mental space. So, for example, in trauma treatment, one symptom is people who suffer from PTSD. One symptom is a replaying of the tragedy, the accident, the violence in a person's head over and over. So that is an instance when there's an over adaptation, when the mental imagery is really acting as a stressor. It's doing a disservice to the person. And so the idea is, how can that imagery, that painful imagery, be stopped or somehow mitigated? And of course, in treatment, what we'll do is there's different ways. So we can use exposure. So for example, if someone was involved in a car accident and they were crossing a street and they get hit by a car, so they're afraid to cross the street. And this has caused some sort of PTSD diagnosis. So the idea is to expose the person in a very careful way, of course, a slow-paced manner. When they're ready, take them back to where the accident happened and expose them to that scene, and somehow get their own psyche used to that experience in such a way that it'll short circuit these negative images they keep having of the accident. So that's called in vivo exposure. But there's another type of exposure that we can use called imaginal exposure. So imaginal in this context means to use mental imagery. So you can do it right in your office. You know, there may be a reason why you can't go to the place where the tragedy happened for whatever reason. But you can do an awful lot just in an office using mental imagery for something like the treatment of trauma. And not just for treatment of trauma. In fact, for many disorders or many problems that people may be struggling with, using mental imagery is a very a powerful way to reframe and to reshape how a person is having an experience. I should point out that like everything else, it's actually a little more complicated than I'm presenting it, because apparently some people do not have mental imagery. So they call that aphantasia. And then on the other extreme, you have people who have very, very vivid mental imagery. And it's a continuum. Most people are somewhere in between, right? So most people can manipulate and engage in mental imagery making to some degree. But as I said, there's always going to be extremes, right? And then, but at one extreme, you have people who cannot do it at all for some reason, even though they're perfectly conscious in other ways. And then on the other extreme, you have people who they have very vivid mental imagery. So it shows us that among individuals, there's vast differences in how features of conscious interiority play out. Some people have very well developed, certain features are very well developed, and then other features, for whatever reason, are not that well developed. So spatialization also affords a location to visualize different selves. So it grants us a virtual space for what are called loosening techniques to kind of snap out of a role, perhaps, that is a negative role that is dominating a person's life, so that alternative possibilities, fantasy, imagination, mental experimentation with opposite behaviors of what we would usually do. In other words, trying something new, leaving one's comfort zone. So mental spatialization, as you can see, has a host of positive benefits. There's been a lot of research on mental imagery. Again, there's nothing new here. It's just that I'm trying to use it as an example to show how, as a feature of conscious interiority, these are the things that we should be cultivating, not just for people who are challenged with mental health problems, but for all of us. So in any case, I think maybe I've said enough, and I'd be very happy to hear any comments or questions that people might have.
Thank you very much, Brian. Let's go to Q&A. So folks, we got 4 rules. As always, go ahead and type ! if you'd like to speak, or raise your hand in Zoom. Rule number 2, keep on topic. Rule number 3, be brief. And rule number 4, speak your mind authentically, disagree with anybody on anything, and do so courteously. So go ahead and type ! if you would like to ask a question. This is the time for questions. Okay, we're going to start with Jyoti, followed by Olga. Jyoti.
It's a very interesting concept, the mental space, but it seems like the client is doing all the work. Can you tell me where does the psychotherapist come in when the patient is doing this kind of mental imagery, and how does therapist facilitate that? I'm a little confused about that.
Okay. Thank you for that question. So that's very interesting what you said, that you said that it seems like the client does all the work. Um, in a way, you're right. I mean, I would rephrase it a little bit differently. I would say the client does most of the work. And usually, for most problems with mental health, the client is expected to do most of the work. The role of the therapist is to act more as a facilitator, as a guide, to engage in perhaps some psychoeducation, to point to some resources, to train a client, for example, on how to use a particular technique. So there's no way, of course, that a therapist can get into someone's head, literally or figuratively, I suppose, in order to fix things. It really comes down to the client agreeing to whatever intervention is being proposed. And that's why, in fact, an important common factor is collaboration and a consensus on what goals are to be achieved. Because if there's no agreement, then the client and the therapist cannot move on to more specific types of interventions, such as using mental imagery. And as I said, not all clients will be up for it. You know, some clients are more have a more what should I say, a sort of more verbal oriented way of healing their mind. They feel more comfortable just talking about it. So it really depends on the client's capabilities. It depends on what the particular diagnosis is, or what the particular problem is. Um, there's really no one way to treat a person. So yeah, I can see your point. You know, that it seems like the client is doing all the work, and as I said before, in a way that's true. I wouldn't say all the work, but they are doing most of the work. Um, so I don't know if that answers your question, or satisfies. That's a satisfactory answer, but that would be my first response.
Go ahead, Jyoti. You want to go ahead?
I'm not quite satisfied, because this is for a client, it is the mental imagery is a very complicated process. And it can, the two can be at a different wavelength from each other. Because if the client is not very sure where to compartmentalize his or her problems, and I think it is the role of the psychotherapist, if he's using that technique, to guide the client rather than depending wholly and solely on this client to come up with a strategy to place his problems somewhere.
Mm-hmm.
And I can see the two at a different, they are not together on this.
Mm-hmm.
And how does a therapist like help to cultivate these problems, this technique, so that they are both on the same page? Right. Am I making sense?
Yes, yeah, that makes sense. So the way I would answer your question is, of course, when a client comes in, we just don't start, oh, okay, let's engage in some mental imagery and see where that leads us. So the first thing we do the first thing we should do, I believe, is build a therapeutic alliance. And what that means is to put the client at ease, to let them know that they are in a safe space. Whatever problems they have, confidentiality will be maintained, will be protected. They can talk about whatever they want. They can go at their own pace. That's the first thing. And that actually is a common factor, a very important common factor from apparently from a lot of research that's been done. Then the next thing, once the patient is at ease, is to do an assessment. And this is where it gets a bit tricky when we do an assessment, because ideally an assessment could take 1 or 2 sessions. And the idea is to look at the whole person. So I'll ask about the client's medical history, their substance use. I'll ask about family support, any problems with family, what are they presenting with, what problems, is it depression, is it anxiety, or is it an interpersonal problem? And the form I use is 4 or 5 pages long. And so this is the problem, because when you start asking those questions, you're threatening the Therapeutic Alliance, because the patient may feel that you're interrogating them and that you're just another nothing against the medical profession, but you're just another doctor going down a checklist. So it's very difficult in order to do an assessment while building a therapeutic alliance. But ideally, if you're a skilled clinician, you're able to do that. You're able to make them feel relaxed and confident while at the same time getting information from the client on what their problem is. And then once you find out what the problem is, then you start to talk about goals. What exactly is the reason you came to see me today? What is bothering you? Probably there's going to be, could be 4, 5, 6 reasons, but what I try to do is narrow it down to 2 or 3 problems and say, okay, well, let's work on those 2 or 3 problems. That's why you're here. So we know what the goals are. Now the next thing is objectives. Let's find out what we can do to reach those goals. And that may take some time. There'll be some short-term goals, maybe some longer-term goals. And then to get even more specific with the client, then we start to talk about interventions and specific techniques that are tailored to the problem, that are tailored to the individual client. We try to individualize the interventions, individualize the treatment. And that is when the use of mental imagery might come in. It may not come in for different reasons. It just, the client, I may suggest it depending on what the problem is. But as I said, some clients like to engage in mental imagery, some don't. Some clients are more intellectual. They like to write about their problems or talk about their problems. So some clients express their mental issues physically. So some have somatic presentations, maybe a psychosomatic issue that tells me as a clinician what the problem might be. So mental imagery is something that has to be done. In fact, all these features of conscious interiority, I just use mental imagery as one example. They all have to be done within a certain context, and they are part of the intervention that probably would not be used until maybe the second or third session, depending on what's going on with the particular client. So, does that make sense?
Okay. I think it's a very large question. We wanted to spend time on it because it kind of defines the role of both the client and the therapist. So I think that is a good way of fleshing it out. Next questions are going to be by Olga, Kimberly, Mike, Candace, Dave, and JM. Olga.
Thank you, and it's a really great presentation. And you used a lot of great images in it, and it's very unfortunate that there is no artist names or at least links to websites that we can go and see maybe more of these images. But my question, I have several questions, but one of them is on one or more images, there was night sky. So why did you use particularly this image?
I'm sorry, which image are you referring to?
With night sky.
The night sky?
Yes.
Well, no particular reason, actually.
No particular reason if you choose it and post it, and why? There is some kind of, there should be reason especially so, like a professional psychotherapist and
Okay.
Yeah.
Uh,
Yeah. No, I think maybe, actually, maybe there is a reason. Because when I saw the night sky, I thought of space. And when I think of the individual human mind, I think that, like space, it is infinite. And we don't really know what the boundaries are or where it goes, and that there is untapped potential in the human psyche, in the same way that there is a sort of horizonless expanse in space. And so, I think probably that's why that particular uh, uh, graphic appealed to me, because it symbol for me personally, it's my personal opinion, it just symbolizes what the human mind is. The human mind is infinite in the same way space is.
Thank you. Next up is going to be Kimberly, followed by Mike. Kimberly.
So my question is, in the spirit of confidentiality, I'm currently in therapy because of a lot of issues related to
Folks, I just want to interject here. No personal issues we can discuss. We can.
No, I'm not gonna. No, I'm talking. I'm just letting people know. So my question was, I put it in the chat, was that how does imagery relate to dreaming? Because I dream all the time, and I usually remember all my dreams, and I share my dreams with my therapist.
So, the way I look at it is that dreaming is a type of consciousness, a type of Jaynesian consciousness. It's not exactly full-blown Jaynesian consciousness, but it is consciousness nevertheless. And so in the same way that we have imagery while we're awake, of course, if we can be conscious while we're sleeping, even though it's a restricted type of consciousness, there's no reason why we can't have imagery either. So, dreaming in the history of psychotherapy, dreaming has really played a very important role. There's of course, a lot of opinions on it, because some people criticize the use of dreaming in therapy, because they say, it has Freudian associations, and dreams are supposed to be just random thoughts that our mind tries to tie together. So I know some therapists don't take dreaming seriously. I can just give you my opinion on it. I do believe that every now and then, even though most of the time dreams are random thoughts, sort of stuck together in a sort of surrealistic narrative, nevertheless, many times we do have dreams that do mean something. And certainly if a client comes to me and they want to talk about a dream, I'm all ears, because I think that, the fact that they want to talk about it must mean something. And so in any case, dreams have been used to help people since, we all know this, of course, since ancient times. Dreams have a very storied history in attempts to heal the psyche. And of course, we usually associate dream analysis with Freud, but so dreams, they occupy a very in a sense controversial but interesting place, I think, in psychotherapy. So there's a lot more I could say about that, but that's just sort of my initial response to your question.
Thank you. Next up is going to be Mike, Candace, Dave, and JM. Mike.
I'm distilling out of what you've said, and I need some help in putting it together, is that you've invoked, which James has already somewhat invoked, the concept of time into this situation, into the how the mind works, and that once you do that, you are opening this thing up to the continuum of time, into all the quantum effects that enter into this, and the uncertainties and even acausalities of that. Now, in that sense, that kind of brings us into the declension of being versus becoming versus what was, and that the path of psychology is how to move, how to take from from being to becoming, taking into account where you were in that declension. Now, I have now I've also seen one more point is that Penrose wrote several treatises on bringing time in, but not quite as clearly as you and James is doing it. Is there some? Can you shed some light on how all this works in the next and what the next step is in bringing time into this, and whether this being versus becoming, and to try to bring you to an end state fits in all this.
Okay, thank you, Mike, for that question. So I believe, I think a few weeks ago, I think I actually gave a talk about time, right? Is that
Yes.
um, so I'm trying to remember exactly what I said, but in any case, let me begin by saying this argument or dichotomy between being and becoming, that people have been discussing that for a long time. My personal feeling is that it's better to look at a person in terms of becoming. And of course, this relates to this idea of time, that in the same way Homo sapiens as a species is evolving biologically and also developing culturally, individuals are always engaged in self change, in some, however you want to describe it, some sort of progress. And that's because the mind is constantly, like a computer, updating, because it's constantly absorbing information from the environment every second. And so there's really no sense of standing still, I think, when it comes to being a person, where our mind is always upgrading, always really becoming something else. And many times, of course, that progress encounters a hindrance, or it goes off rail, something happens, and of course that's when we all need help, whether that help is through psychotherapy or spiritual or medical, or just talking to someone. But it's always important, I think, to be aware that we are changing. And this is a very, of course, a Buddhist way to look at it, but more specifically to talk about time, why time is important to understand psychological processes. As I discussed before, time is really a resource. It's something that has value in itself. So what I mean by that is, because of certain features of conscious interiority, such as self-narratization, we can envision ourselves in the future. We can envision different versions, different avatars of ourselves in the future. We can plan out different paths of behavior. And no other species can do that. And I think that's one of the defining features of what it means to be a person. And if you look at human history, the ability to plan out the future has become enhanced. It's become stronger and stronger. I mean, we have a whole, this whole science fiction idea actually is rooted in the mental ability to self-narratize ourselves into the distant future. That's an ability that did not exist until just a couple hundred years ago. So we're talking about two levels. We're talking about how the individual can use time as a resource to plan for their own future. And we're also talking about Homo sapiens as a species developing new mental capabilities, using technology in order to predict, in order to better plan um, uh, uh, for the future. It involves actually a fair amount of what we might call social engineering. Whether that's a good thing or a bad thing, of course, I think is debatable. But in any case, Mike, I'm not sure if that answers, if that addresses what you brought up. But
Thank you.
hopefully.
Thank you. Let's. There are lots of people waiting in line for, but I think you covered it pretty well. Next up is Candace, Dave, JM, Laura, Peter, and Alvaro. Candace.
First, I'd like to say thank you again, Brian, for such a provocative presentation. I've really enjoyed them. And I thought you did a fabulous job characterizing the fluid and organic nature of how we process information. So my question is, remembering that I'm Adlerian trained, so you have at least some contextual framework for my question. You, several slides ago, you showed or shared some things that some of your clients had said. And it was fascinating to me that some of them used the term "my head." So they had not internalized their thoughts or feelings to the I or the me. The reality was still outside of themselves and separate from themselves, almost as if they were objectifying their head apart from their selves. So how would you explain that relevant to the concept of mental space? And I ask that because as Adlerian trained, I'm interested in the interplay between the unconscious, subconscious, conscious, unique to the concept of generalized FOCI. So how does that all come together?
Yeah. So thank you. That's you actually brought up a lot of important issues. I'm not sure if I'm going to be able to answer them for you, but it's certainly a lot to think about. So yeah, it might be, I think some people might debate this idea that when they use the metaphor of my head, that they have not internalized it or whatever is bothering them. Some people might say, well, they've internalized it to a degree. But I guess it all comes down to they're basically using metaphors, because we know that these problems or whatever is ailing them is not in their head literally. But the fact that they are connecting it at least to their body, I think, is a good place to begin with them. And the way I view it is, lately I've become more and more interested in this idea of somatic psychotherapy, using the body itself. But many times when we use a body, we're using the body metaphorically, as in the examples I gave. But just because these are metaphoric examples does not mean that they're purely intellectual experiences. And so the idea is to somehow, and I'm not saying I have the answers exactly how to do this, but somehow to persuade the clients that if they can visualize certain problems, for example, something existing in their head, that it's not a big step, but it is a step in the right direction toward self-control or self-autonomy. Okay, so now we've identified what the problem is. Now we're talking about where the problem is. Now let's take that problem and maybe externalize it completely out of your head. Let's imagine what it would be like not to have that problem in your head. Try to narratize yourself in the future, or narratize a different version of yourself without that problem being in your head. And again, this starts to draw in other foci, as I said, such as self-autonomy, self-authorization, self-narratization. And also this the other thing that I think is important is this idea of acceptance. So you say that you have something in your head. Well, it's obviously bothering you, but let's talk about how those feelings are bothering you. Let's talk about, is it really so bad? Let's talk about maybe there's a different way to reframe those problems, whatever they are. Rather than talking about those problems being in your head, let's accept them, but let's put them in someone else's head, for example, or let's put them out on the table, the coffee table that's separating us, and look at it. I mean, that some of that I think sounds a bit gimmicky, but it always amazes me how clients are at least willing to do that, and how this is a first step toward seeing that whatever problem is existing in their head is not them. It's just a part of their selves. It's just something in their head. Let's explore other parts, or let's explore what else is in your head. And so again, this, metaphors sort of traditionally have gotten a bad rap because we think of metaphors as being somehow not real, or a type of illusion related to poetry, things that are fictional. But in fact, everything goes back to metaphors. And so if we can show people the power of metaphors, then it becomes a lot easier to talk about what their problems are. It's very difficult sometimes to identify what's bothering a patient because they have not developed a vocabulary yet in order to verbalize and articulate their problems. And so what I always suggest is, let's, assuming what type of background, what type of educational level that they're coming from, let's engage in some metaphors. And again, it doesn't take care of the problem necessarily, but it's just a way to conceptualize and to put in a framework to show the client that actually these things, we can talk about them. We'll talk about them in a sort of poetic way, perhaps, but once we start talking about them, hopefully you'll begin to feel a stronger sense of self-autonomy, and maybe start to draw things out of your unconscious, start to draw things out of your subconscious that are there, but you have not been able to explicitly, clearly verbalize whatever those things are.
Excellent. I think this is a great point with the idea of metaphors and the role of metaphors in human affairs is a very large point of Julian Jaynes, because what metaphor does is that it takes something that you're more familiar with, and you're using it and leveraging it to deal with something that you're less familiar with. And especially between two people, when you're trying to actually communicate, metaphors are very powerful because you can talk about something that both of you can see very clearly, and then you're referring to things that you can't see that well. Right. Things which are not as conscious, which are kind of implicit, and you're leveraging the fact that commonality of things that you can see to get at things that you can't see, both for the patient, person themselves and in communication. Wonderful. Next up is Dave, followed by JM. Dave.
Very wonderful presentation, Brian. And the pie chart about the effectiveness of therapy reminded me of a lecture I was listening to recently of Jordan Peterson. And he was making the statement, it's a miracle, a couple of things, that the client realizes they have a problem and then presents themselves for treatment. Says that when those two things happen, you're halfway there. Would you like to comment on that?
Yes. So, yeah, I think that's a good point. So, many times I'll tell a patient, the fact that you came in was an act of bravery. Many people have a problem like you do, but they don't want to come and get help, and that's understandable. But it does take a lot of courage, and also, I try to look at it from the angle of positive psychology. That let's talk about what strength did you have? What was it about you that encouraged you to come in? and let's identify that and build upon that. And so, yeah, you're absolutely right. I mean, unfortunately, what happens many times, I'm sure you know, people, they'll come in for 2 or 3 times and then they don't come back. You know, that happens too. But nevertheless, to try and be positive, yes, that's because they're once they come in, they're making a commitment that they want to get help. And now it's just a matter of more clearly identifying what the problem is and coming up with some interventions.
Thank you. Next up is JM, Laura, Peter, and Alvaro. JM.
Hi. I had a quick question. It's not too in depth. It's just kind of like for information resources. Do you know any good like resources or books on like mental foci and how they're used in therapy outside of Julian Jaynes, I guess? Because I'm not really familiar with all this, but it's super interesting. So maybe like maybe like books in that specific topic that you're aware of that might be interesting for to read, maybe for me, or maybe anyone else is interested.
Yeah, so the way in this presentation today, I listed the foci, but actually that's my particular packaging of features of conscious
Okay.
interiority. So there's no, right now, there's no, I am working on a book that examines those particular features of consciousness and I try to interlink them into particular techniques and interventions. You know, but to answer your question from a more practical angle, what I would suggest is I would start with what I talked about today a bit is imagery, because that's most people seem to be able to relate to that. So I would because there's maybe 100, 200 different techniques supposedly that people use in psychotherapy. So there's so much stuff out there. So what I would do, as I said, I would start small, start with something that's very concrete. It's easy to get our minds wrapped around, which is mental images. And I can't think of it now off the top of my head. There are actually 2 organizations, I think one's based in New York, that focus on mental imagery. One in particular, I think the other one is out in California, and they look at mental imagery from a therapeutic point of view. You know, if you want, if you send me in the chat, if you give me your email, I'll try to track down those 2 places, because these places, they probably have a good list and good resources for you or anyone to explore mental imagery.
James, one more recommendation.
Okay.
You know, Brian has done about 20 different videos on this concept. And actually the foci concept is something that is the way in which he has summarized insights from Julian Jaynes. And he's done a very good, so I've put in the chat, I've put the playlist, which is basically all of his videos in the past meetups that we've done. And what we're going to, so that's a good place to start. You can look at go by the dates. Initially, we went and established the basic concepts of what core of it is the mental space. That's the concept. And everything else is kind of, talking about different aspects of that. So this is very much of Julian Jaynes' ideas that Brian has developed. So those videos are a very good place to begin to explore what the foci are. Thank you. Next up is going to be Laura, Peter, and Alvaro. Laura, you can ask any general question, okay? Not about individual questions. Go ahead, Laura. Laura, you're on mute. Okay. Next up is going to be Peter, followed by Alvaro. Peter. Peter, go ahead.
Okay. are there any particular mental health diagnoses that limit or impede a person's ability to use mental space more than any other diagnosis in particular? And what approaches might help here? And I'm asking as a mental health carer and a peer worker.
Thank you. I don't think there is a particular, in the DSM-5, the Diagnostic Statistical Manual, I don't think there is a particular diagnosis for people who cannot evoke mental images. I might be wrong on that, but I'm pretty sure there isn't. However, there is a term, and I mentioned before, that recently people have been talking about to describe individuals who cannot bring up mental imagery. It's called aphantasia. That's maybe I'll try to put it into the chat. Wait a second. I don't know if that, I don't know where that went.
That's fine.
But in any case, yeah, it's Aphantasia, aphantasia. And so I would start there.
All right. Excellent. Next up is Alvaro. Alvaro, what's your question?
Hello, Brian. I'm going to try to ask a question, but I'm not a psychologist. So my apologies in advance if I'm mistaken when framing the question. But I wanted to mention that a couple of weeks ago, there was another meeting here called the Networked Brain, in which it was shown how the brain changes with events such as trauma. And I wanted to bring up the case of PTSD and or trauma, especially when it is ongoing, and maybe point out situations like in the past, such as slavery, or even more current ones, such as discrimination, especially when it is ongoing. And it can even be something like bullying at the high school or middle school as well. So my point being that what I understood is that the approach in this psychoanalysis is that you will tell the client that the person is having conscious inferiority when it comes to their issue. And it seems to me that it's basically implying that it is something that the client is deciding or basically embracing that inferiority, and that it's only in his or her head. So my question is, bringing up these examples, is how can, after seeing that trauma does have effects in the brain, in the physical brain, and after experiencing something as real as it may be slavery or discrimination or bullying that is ongoing, I feel it is a little bit tone deaf, if you will, and my excuses if the term is too strong, to tell the client that he's embracing conscious inferiority instead of actually having a real issue that is ongoing.
Thank you, Alvaro. Go ahead, Brian.
So that's a very, thank you for that question. That's actually I think a very relevant question. It's a little bit difficult to answer. So my feeling on that is, if a client comes in and they say that they're suffering from PTSD because of something that happened in our histories past, such as slavery, I follow the DSM-5 to see if they actually have symptoms. And I guess in theory, they might have symptoms, but if they don't have symptoms, I won't give them a diagnosis for PTSD. However, that does not mean that they do not require some counseling or some treatment. And so specifically with the presenting issue that you mentioned, I think you were talking about inferiority What I would address that by focusing on the features of self-narratization, self-authorization, self-autonomy. And of course, today I did not talk about exactly what those terms mean and how they play out in a clinical setting. But for the type of person you're describing, they most certainly require, I would say, some counseling. What type of diagnosis I would give them, that gets a little bit more complicated. But just because we don't give a diagnosis, or we can't find an adequate diagnosis, does not mean that the person does not need some sort of treatment or intervention. So it's actually a kind of a controversial issue, I suppose. When does someone need, what happens if you can't give a diagnosis? But like I said, my personal philosophy is that there's a very gray area between a clear-cut diagnosis and then someone who is under some sort of mental distress. And just because we can't give them a diagnosis, they're still under some sort of mental distress. So then it becomes a question of figuring out what type of treatment would be most adequate. And like I said, for what you're talking about, I would begin with looking at how to build up their self-autonomy and self-authorization.
Wonderful. Well, thank you very much, Brian. And thank you very much, everybody, for great questions. Brian will be back 3 weeks from today. Next 2 weeks, we have kind of traveling conflicts, but 3 weeks from today to continue this series. And Brian, I think this series is going really, really well.
Oh, thank you.
We are going, and folks, I am surprised. I was just looking up the playlist. There are 21 videos that we have done so far, most of them by Brian. There are a couple other from other people on Julian Jaynes. And Julian Jaynes, he has very deep ideas about this. And I'm very excited about Brian applying them to kind of personal growth and psychotherapy. I mean, one observation I had, Brian, is that it's actually kind of, if you step back and look at it, look at the study of, the pie chart, it actually is a very profound humanistic point that a lot is dependent on the individual, what the individual does as a client and what the individual does as the therapist. And a lot of those things are not just in the context of therapy, but it's just in terms of both human beings and human interaction itself.
Yes.
So things like, whether the relationship is good or not, that I'm sure a relationship of a good friendship does things for you in terms of your personal growth and mental health.
Yes.
Significantly.
Yes.
And all of that, it's kind of like the substrate on which these specific ideas rest. And these are kind of universal principles. And that's the thing that I got from it.
Oh, good. Yeah, I think you're right. Yeah.
Wonderful. All right. Thank you very much, everybody.
Thank you. Wonderful questions. Thank you, everybody.
I want to tell you about one meetup that is coming up tomorrow, which is going to be incredible. My friend Yasuhiko Kimura is going to be back, and he's going to be talking about the paths of self-realization. West looks at intellectual endeavors very differently from the East. West, for example, regards philosophy as love of wisdom of how to function in the world. Whereas East comes at it from the perspective of self-realization. And he's conversant both with the East and the West. And we're going to be talking about the concept of self-realization and different traditions, how different traditions look at this. So look forward to seeing you there tomorrow at 5 p.m. Eastern time. See ya. Bye. Thanks, Brian.